Thanks for having me here. My name is Mark Jaffe, and I'll be speaking for about 19 minutes and 30 seconds. I've got my stopwatch here, and so make sure you yank me if I go over. I'll be sticking around, so if you have questions for me, feel free to ask me, maybe not during the middle of the talk, but at the panel discussion, or find me afterwards. So I want to talk to you about the Kaiser Permanente experience, which sounds like a ride at an amusement park, but actually it's a serious subject because I want to talk to you about how we address hypertension from a population level using strategies and programs. So here we go. My disclosures, I don't have any financial disclosures. I have a funny job. I worked for 25 years at Kaiser Permanente in Northern California, and then for about 14 months ago, I was sent on assignment to work with Dr. Tom Frieden in the Resolve to Save Lives initiative. So now I work out of New York and mostly work internationally, China, India, Ethiopia, Bangladesh, Vietnam, in third world, low and middle income countries to help set up hypertension systems as well as reducing sodium and trans fat. But still, I'd like to share with you how it is that I approach system care, how to help the doctors and the patients and the staff operate in a system. So the objectives are to recognize the key elements of a successful hypertension program, to utilize performance information to identify best hypertension practices, and describe how a simplified drug treatment protocol facilitates successful hypertension program. So this was published in August of 2013, where we described our experience. And what we wanted to share with people is how we went from really, I would say, not so enviable hypertension control, about 40% control, up to about 80%. And since then, we're hovering between 80 and 90% hypertension control in the patients we've identified with hypertension. So let me tell you a little bit about Kaiser Permanente. There's 4.5 million members, 8,000 doctors, 21 medical centers, about 250 offices, and it's like the Veterans Hospital, I think, where the hospital, the drugs, the pharmacy, all the staff it's all paid for. So there's not so much a question about billing. And when I talk about, sometimes we do a lot of phone calls or we have a medical assistant do a blood pressure check. When people say, well, how do you bill for that? I'm the wrong guy to ask. I can just say that when you're thinking about the system in general, that sort of makes a lot of sense to involve many ways to contact the patient and many people on the team to help make sure that that works. So this was from our 2016 paper where we described the elements. And I think when I list these elements here, I just want to point out that these are not unique to Kaiser Permanente. Many of these were present in Dr. Egan's talk earlier, and these are also present in the WHO Hearts technical package, and they're also present in other places as well. So what we find useful is to have a registry, which is a list. Like, how are you going to, like, if you said how many babies are vaccinated in your county, well, the first thing you'd want to know is, well, how many babies are there? So really, if you want to get hypertension under control in your community, in your clinic, in your setting, the first question is to get some sort of a list. The technical term for that is a registry. The next thing to do is to do something with that list. You don't just say, here's the list, and then see you later. It's to say, well, of those people on the list, how are they doing? And to provide some sort of a ongoing metric about something that you think is important, something that will drive care. You got to be very careful what metric you pick, but you should pick something so that the teams can say, maybe we ought to do something about this. Maybe we ought to go talk to those guys over there because they have a similar practice environment, and looks like they're doing a little better. And we ought to go figure out if we're doing something different. Also, a treatment algorithm that's evidence-based, and we heard a lot about drug treatment earlier today, and Dr. Egan's slides mentioned some of the drugs that they use, and I'll go over some of that. Also, we use medical assistants, and I would categorize that as task sharing. In other words, usually the doctor or the pharmacist is the quarterback of the team, but oftentimes we have the patient come back and have a highly skilled medical assistant, meaning the medical assistant is trained on how to do a blood pressure, and in many instances, you could argue that the blood pressure by a trained medical assistant could be the same and or better than a clinician because sometimes it's hard to teach an old dog new tricks. I'm just thinking for myself. So we don't have any data to support this, but I wouldn't be surprised if the performance on an accurate blood pressure measurement done by a trained staff member could equal or exceed that of a physician who, as you know, it's hard to train, teach, and monitor and tell doctors what to do. And I'm a doctor, and I don't like being told what to do, so maybe I'm projecting. And then also, we use a lot of single pill combination therapy, which I'll mention here. And I would say single pill combination therapy really falls into the category of making sure there's a consistent drug supply. So basically, if you're going to recommend certain affordable, high-quality drugs which are recommended based on a national protocol or your clinic's care recommendation or the formulary in your community, you're going to want to make sure that the drugs they're available and affordable. So when you don't have to look at all the fine print on this slide, but if you look at the Heart's technical package, which was produced a few years ago and was recently updated, H is healthy lifestyles, E is evidence-based treatment protocols, A is access to medicines, R is risk scores, T is team-based care, and S is systems for monitoring. So that's the same thing I just mentioned, and that was developed independently. And then before I joined Resolve to Save Lives, and then Dr. Welton was involved in some of the setting up of this, these were the actions that were felt to be important. So I just want to point out that multiple people working on multiple projects are sort of coalescing to this core of key elements that seem to be important to implement programs. Drug protocols, community-based treatment, and what that means is that you don't have to drive past 6 villages and 2 boats and 3 buses to get from your rural health setting to the major hospital. This is what this means in Vietnam or India. It means that someone else other than the doctor closer to your village can take care of you. In Kaiser, this means, well, maybe the medical assistant can help. But it can mean anything in any one of your practices. Medication supply we talked about. Patient-centered care means it means doing all of those things I mentioned so it's easier for the patient. And information systems, which is data. So question 1. Which of the following are elements of a successful hypertension treatment program? Looking at all 3 of those different systems I described. An evidence-based simple protocol, registry and performance feedback, task sharing, access to single pill medications or any medications, or all of the above. How many people think it's number 5? All of the above. That is right. I'll make it easy for you. So everyone should get full CME for this session. Is that right? Okay. So what's also interesting, if you look at the literature about what's useful in systems, Glynn et al. Published in 2010, the most effective intervention to improve blood pressure control in primary care settings is an organized system of regular population review rather than primarily patient or clinician-focused interventions, which I thought was interesting. So drug detailing or patient education, that doesn't seem to work. What seems to work is just letting clinics and doctors and staff know how they're doing. And that's how a lot of things improve. So what should a hypertension registry look like? Well, it should identify most people in the community with hypertension. And community is a funny word because some people think a community is only the patients that come in to see me. Other people think a community is everybody that my clinic really serves, whether they come and see me or not. And so I think that's a really important question. It's what's the denominator? It probably isn't only the patients that see you. It's probably all the patients who would consider your medical care site the place where they would get their care. This should be validated. It should be periodically reviewed. And it should be updated regularly because people move and they come and go and more people are added. Not too many people are de-diagnosed, but occasionally there are people you want to remove for one reason. Maybe they're on hospice. So there's a few patients you might want to remove. And then also the number of data elements in that registry should be determined but based on how much energy it is for data capture. I know that, Brent, didn't you start the first system with postcards?
We did.
So how many elements did you have on the postcards?
A handful.
How many do you have now?
Probably 40 or so, but limited metrics, but more data.
More data. You see, so again, so I think that there's lots of different ways that you can do it. We started with about 210. We use about 5. Okay, so people collect a lot of information, but I think the ones that we use are pretty limited because primary care is pretty darn busy, and we got to be very careful with what sort of reports we're going to give to them. So you can collect a lot of data, but if it's burdensome, just think about the things which are really going to move the needle. And one thing I would point out, that we talk about what's the population you're interested in, what's your community. We started off with about 350,000 patients, which based on our age-adjusted prevalence based on NHANES, was probably about half of all of our hypertension patients. But after about 11 years, we got our registry to be 29%. No, I think it was, our final registry was, I think it was 28.7%, which turns out was really close to what we would expect based on NHANES. So it's always nice to have sort of an external validator to see if you're close, because if you think the prevalence in your community, based on how many patients you've counted, is different from what you would expect based on something else, then maybe you've got some missing patients, and maybe you want to do outreach activities. So I think it's important to think of all the patients that you ought to be covering as a denominator, not just all the patients that you happen to know about. So I would say that what we did is that we didn't have a metric before 2001, and from 2001 to 2008, we actually didn't have a computer. And I know what you're saying, Mark, you're from San Francisco, Silicon Valley, what do you mean you didn't have a computer? Well, we actually, those people in the audience with gray hair will remember this, maybe still do it. You had to bubble in little things, every time you saw someone for a cough or a cold, or you had to bubble it in and send it in to the, to the company. They could keep track of what you're doing. Well, we did that to a Kaiser. It wasn't for billing, but it was to keep track of what we were doing. So what we did is in the bottom of that little form, we just added some blood pressure zones to put in there, because we didn't want to wait the 6 years it would take for us to implement an electronic medical record. So this is what it looked like. We talked to our administrators. We said, hey, we're doing really bad with hypertension control. Can we just get some blood pressures? So we got all of our doctors, our 6,000 doctors at every visit, to bubble in one of these ranges. And it's not perfect, but the point is that getting information allowed us to provide feedback. So after about 6 months, we got a lot of feedback. So you can see that initially we had ranges of blood pressure, right? We actually did not have a continuous variable. But look how powerful this is. And this was a report, I can't remember, this is so old, I can't remember if this was for a medical center or for a region in general, but you could find a lot of information from this. And this wouldn't be surprising that a lot of people didn't have a blood pressure who we knew had hypertension, and the mean blood pressure systolic was a little higher than we would like. Now, we choose to report mostly on systolic. Now, we have systolic and diastolic measurements, but when we're talking about graphs and for simplicity, because most patients are not going to have isolated diastolic hypertension, it's common. I mean, it's not common. It does exist, but we talk mostly about systolic hypertension for purposes of making graphs easy, especially when we're talking to primary care audiences or non-physicians. So we did this with using ranges. And then we also would do this. So not only would we show the ranges, but when you get data, see what you can do. And we did this about 16 years ago. So we started sharing this with the clinics. And the first couple times we gave them without the doctor names on the bottom. So basically that's at a medical center, and we would share this with the chief of medicine. And the chief of medicine could do whatever he or she wanted to do with it. This was not used for compensation, by the way. This was just used to say, hey, look at the tremendous variation there is. And you know what happened? Well, the people at the bottom complained that the metric was unfair. But what they did is they went and they talked to the people who were at the very top. And it turns out after about 6 months, we started sharing these unblinded. We just put everyone's names on there because we're grown-ups, and it wasn't about shaming. It was about letting people know where they are. And we would have the people at the top, and these are all internists, come to conferences and tell us what they're doing so that the people on the bottom can learn from them. And over time, we saw tremendous decrease in variation, but just by sharing this information. And I think information is power. So they're unblinded. They were started quarterly, and we had to create them manually, right? Oh, one other little trivia question. You see those paper forms? Any idea how those paper forms, This is, I live in the Silicon Valley. Any idea how those paper forms got to our central processing, the optical scanner? Any idea how those things got to the optical scanner?
Fax.
What'd you say?
Fax.
Fax? Any other ideas? Wasn't a fax? Mail? No. Any other idea? What was that? Transcribed? No, trucks. So every night, so here we are, I'm saying, so remember, where there's a will, there's a way. Yeah, these were trucked overnight. At each medical center would have a truck of these, and these would drive to the central processing, which is near Sacramento. They would be scanned the next, but again, it just points out that we did not want to wait 8 years till we could deploy an entire electronic medical record. So people say, oh, we can't do it, we don't have an EHR. It's like, well, we did it without an EHR, you did it without an EHR. If you just if you want to get the data, then you can do it. You could probably do it with sticky notes and a file cabinet if you wanted to. So what we did, we had a central management team looking at all the results to identify best practices. We had medical center teams to support clinicians. We'd have a little champions network. And then we would have meetings much like this. We'd get all the champions together and they would talk about what worked and what didn't work. And then we had clinic level feedback for operational and system change. Yeah, I would point out that we didn't rate the doctors, we rated the medical centers. Because you told the medical center, hey, look, you're not doing as good as that medical center. Maybe you ought to talk to them. And so there actually was a small financial incentive for the medical centers. And that really got the administrators' attention. And so they would get another programmer, if you needed equipment, they would help you get equipment. So we found that the leverage was not incenting the doctor, it was incenting the clinic and the doctor. So number 2, the most effective interventions to improve blood pressure control in primary care settings are organized systems of regular population review, such as quality reports, clinician-focused interventions, such as lectures like this, patient-focused interventions, such as community classes and media campaigns, or screening and outreach. So what's the most effective intervention to improve blood pressure control in a primary care setting? It's number 1. It's an organized system of review. So we had a drug-based algorithm, and I'd point out here that we had many people involved, primary care doctors and specialists, but I would point out that we always tried to have the primary care doctors outnumber the specialists, okay? Because we don't want the specialists telling the primary care doctors what to do. So that's what we did in an integrated care. So we value what the specialist said, but they don't treat the patients. The primary care doctors treat the patients. So we wanted to have a lot of primary care docs. We did a simplified drug treatment algorithm. Here's the Kaiser one. I would just point out that it's just simple. We end up using a lot of lisinopril hydrochlorothiazide. We use a single pill combination. You get a half pill, 1 pill, or 2 pills. You can treat maybe 60 or 80% of patients effectively using that combination. Of course, any doctor could use any pill he or she wanted, but the pharmacy always had that. We had lots of information, handouts to support that use. The medical assistants were trained and knew about that. So although you could use something else, it was easier to use this. And then if that didn't work, we added amlodipine, and then if that doesn't work, we add spironolactone. This is, nothing earth-shaking, except that, we tried to keep it very simple. We tried to really put the dose and the drug right on there. And then I just point out that I put some other cells in here since our publication in 2013, but right now about 1/3 of the prescriptions are for single pill combinations. And we're not going back in time and converting people, although you wonder maybe that would work for adherence, but we're just focused, so most of the new patients get on a single pill combination from the get-go. And it looks like, I don't know if that's the right number, but it's about 30%. And that's where it looks like it's been stabilizing. So a simplified treatment protocol has, I didn't go over this here, but I'll just tell you the answers. It doesn't have lots of options. It just gives you more direction than options. And if you want options, the primary care doctors, they don't tell me I want lots of options. They say, I'm pretty busy. I need some direction. So we try to steer them and give them some guidance. Promotes the use of just a few drugs, not many drugs. It does decrease practice variation, and it doesn't require complex teaching materials because it's pretty straightforward. And also, if you have a simplified treatment protocol, think about it. It can accelerate task sharing because it's simplified, right? You can have the other people on the team. They don't have to have a degree in cardiology or endocrinology to understand the treatment protocol. They can understand it because it's really straightforward. You can focus on the important things. Drug supply and logistics, way more easy, right? If you tell the pharmacy, we're going to need a whole bunch of this medicine. And it's a lot easier to do performance measurement because you can talk to the pharmacy and measure things like that. And easy and does not require consensus building, that's wrong. It's difficult, it requires consensus building. But once you agree on something that you all can agree on, or for most patients, it really it paves the way. Just have a couple more slides here, and I'll just talk about blood pressure office visits. What's nice about it is that while I'm here today, someone could be having their blood pressure checked in my office by my medical assistant, right? And then, you know, it could be in my colleague could cover it, I could adjust it, the medical assistant could have a protocol that says, oh, it's under 140 over 90, that's pretty good. And if I wanted the blood pressure lower, maybe I would call the patient back, but we can have a simple way to engage the medical assistants. And so we really like this, and we do a lot of visits like that. And so when we did this, our control rates now are between 80 and 90%. I think we don't want to go a lot higher than that. It's probably, I think that's, I don't know that you want to go any higher, but we started off really low. We started off actually below the national average at about 40%. And you can see nationally things are, you know, roughly 60%, California about the same, and we're about 20 or 30 points higher. And I think it's because it's a system. We're not better or worse doctors than any of the people in California that we're compared to, but we're just organized and we take it seriously. So it looks like I'm a little bit over time, so I'll just point out that we have 2 articles tracking myocardial infarction. This is in the setting of the sensitive troponin assay when you think heart attack detection would go up. But still, despite this, we're seeing a rise in, you know, ST segment elevation MIs, and most of the MIs we're seeing are non-ST segment elevation MIs. And, you know, I can't say that they're related. I believe that they're partial. I believe that these are related, but I can't prove to you that there was something else which diminished the cardiovascular disease. But my belief is that the hypertension control going from 40% to 80 or 90% made a big difference in what we're observing in Northern California. So anyway, whoops, I'm 2 minutes over, so I'm going to sit down. Sorry about that, Dr. Connell, and I'll take my questions at the end. Is that okay? Yeah, sorry about that.